This episode of Simulation Nation is brought to you by Avkin Incorporated, your one-stop shop for wearable simulators and everything standardized patient.
Hello, everybody, and welcome to Simulation Nation.
Woo.
Today, we are going to be talking about all things psychological safety. So this is a topic that you talk
let's
about
be clear.
a lot.
In simulation.
Psychological safety in simulation. Yeah, we're not talking about external things here. We got to keep it limited. If
Yeah,
not,
we can't cover all those
topics. We'll go
topics.
too far. We'll go too far. Those will be like nine hours. So I think the important thing that we talk a lot about with psychological safety is that we're going to kind of go through a checklist here. But I think the important part is psychological safety is not a checklist. It's not just to go through and check the boxes, but it really is a culture that needs to be created inside of your simulation center. It needs to be the director of simulation being the one to really kind of forefront that, or whoever is your main simulation person needs to be the one leading that charge, but it needs to be carried out through students, standardized patients, faculty members, but really anyone who's going to be a part of it needs to all kind of come together to understand the importance to make sure that simulation is safe for students to participate in.
Yeah, and I think that there is within the Association of Standardized Patient Educators, there is, one of their domains is safety, right? But
The first domain is safety.
Yes, but it's not specific in the healthcare standards of best practice. It is woven throughout. So it's kind of the same idea of your sim center needs to have psychological safety woven throughout, but really, if you think of kind of like one of its pillars or one of its main, focuses, if you guys are writing for accreditation, psychological safety could be one of the main pillars that you're really trying to enforce or uphold. And again, if you don't have psychological safety, at the end of the day, you're either undoing any learning that they've done, or they aren't learning at all. I mean, that best case scenario is that they're not learning, but even worse is that you are potentially undoing things or creating false frames.
Well, and also creating further trauma for being able to participate then in psychologically safe simulation. I've heard that a lot from hospital educators, where they will have people coming in that are just absolutely terrified of simulation because some of the noxious experiences that they've had in their undergrad programs, which then makes them hesitant to really open up and participate in their graduate, programs, to be able to, fully immerse themselves because simulation wasn't done well or it wasn't done correctly. And so not only is it undoing learning, but then it's starting to prohibit future simulation learning because there's a fear or stigma around it.
Yeah, and I've shared this story before. It took me many years to talk about this, and it's not something that happened in simulation because they didn't have simulation when I was in a nursing school. But one time I made a critical error with a pediatric patient, and it didn't hurt the patient, but I basically left the side rail halfway down and went to the sink, which was about 5 feet away. And my instructor walked in the room and saw that I hadn't put the side rails all the way up. And I knew I was supposed to. I was being lazy, and it was wrong. And I got reprimanded for it. But what happened in post-conference with all of the other nursing students there is that he knocked on my head and asked if anything was in there in front of all of my peers. And I was so embarrassed by that. And it was something that I'm getting tearful about it, but it was something that brought trauma forward, even as to whether I was going to be a good nurse. And I think that it can, if you're not careful, and if you're not very intentional with how you enact, your policies and procedures, your culture, your simulations, your debriefing processes, all of those things, if you're not thinking about that, you actually could be doing more harm than good. And it is something, I think a lot of us have those stories. A lot of us from, back in the day, I guess, and maybe even today. But we don't, that is not helping anybody be a better nurse.
Yeah.
And I think that it's just really important that we spend time on this and that we have the discussion. It is something that we talk about quite frequently and is very near and dear to our hearts. We're really kind of going to go in two pieces with this. So there's the psychological safety that we all, as simulationists, are very aware of as far as learner psychological safety. But then there is another aspect, which I mentioned a little bit, but the standardized patient psychological safety. So when you have standardized patients, and again, that's our specialty, that's our expertise, that's our wheelhouse, we also want to speak to that. So this is going to be kind of in two parts. The other piece of this that I want to put it kind of as a disclaimer is we're not going to cover every single aspect. What we're trying to really do here is point out some things that are not super clear in the literature. So your debriefing style, your pre-briefing pieces, we'll go over that a little bit, but there is a lot of really good literature about what to do for that. But really almost trying to kind of think about things that we've heard along the way as we've done consulting or as we have interacted with other simulationists that they struggle with, to point out some things that maybe are happening that you're not even aware that could be contributing to either a negative culture or some unpsychologically safe pieces.
Yeah. And I think the unique part here is, from my perspective, as someone who was a standardized patient for many, many years, I saw the full gamut. And most of the time, I'd say 95% of the time, no one is intentionally trying to create an unsafe psychologically environment, right? They're trying to create an environment that is learning and things like that. But I think just personalities and things that come up, it leads to these comments or situations that they're not aware how formative these are for students. And being that kind of third party watching, being there but not really being observed or noticed that I'm there, I've seen the gamut of what can happen with small comments, small decisions that can then lead to environments. And again, being able to kind of share some of those. But I think some of this can be, there's two portions here where you can look at it in terms of comments that are made or situations that arise. But then there's another component that Susie touched on recently, Susie Carden-Egren. She posted on LinkedIn basically in all caps and just put, "Do not scare your students in simulation." And I think that this is a mindset or culture that has to be reprogrammed. I think when we started in simulation, there was this mindset of, let's throw the book at them. They got to learn everything. We got to put everything out there. We got to give them all of the worst patients that could have possibly happened. And I hear that more frequently from other facilitators, that when you have other faculty members come in to play the role of the patient. So not your typical standardized patient, but when you have another faculty member come in, they want to then portray the worst, all of the worst patients that they've ever had. They want to combine all of them into one 30-minute segment to kind of see and test the students. And it's kind of, I'll throw out this test and see how they bite. Then I'm going to throw out this test and see what happens here. But the going off the rails happens much more frequently with having other faculty members play the role of the patient, because they are trying to, show them all of the possibilities. And I hear that more frequently than I do with standardized patients going off the rails. I feel like that's the more common thread that I hear in simulation.
Yeah, I think Susie being at Harvard, that's really kind of the hotbed of psychological safety in simulation. And, the idea or the concept of don't scare your students in simulation, it's kind of like, that's just a fundamental.
Yeah.
So I love that.
We want it to be a fundamental, right? Because I still even hear people who will be like, I'm ready to do this really hard sim. And those are the conversations that scare me in terms of like, that shouldn't be the exciting part of simulation, that we are getting under students' skin.
Yeah, but I think fundamentally, like what you said at the beginning, is that nobody's doing this with the intention to hurt the students.
I think the mindset is it's fun. I think it's kind of this like, it's a fun situation.
From an educator's perspective, you feel the weight of the responsibility of preparing the next generations of learners. And one of the things that I teach to the standardized patients when we teach standardized patients is you have to think of learners as a sculpture, and that you're working on pieces or bits of it at a time, but you're not going to go and start taking the chisel and hammer to the middle of the piece and start not being careful.
Huge chunks fall off.
So it is one of those things to almost give the facilitators or the simulation educators permission not to complete their education in one course, or to help them understand. And I think by and large most educators understand it, but because there's such limited time in simulation, the idea is let me get as much out of this as possible. But what ends up happening is it does overwhelm them. But let's get back to some of the fundamentals of this. So, and I want to make sure we mention it, and it is like I said, there's plenty out there in the literature, especially if you go to Google Scholar and you type something in and there's a link off to the right, it's a free article. It's an open access article. So if you don't have a great library of books, or if you're not a member of some of the associations that have journals, there are still plenty of resources. The healthcare standards of best practice are free resources and free access that you can get at any point in time. I think, so let's start with the big top. Okay, so in simulation planning, the very beginning of this, so if you think of the context and the background, what are the needs? Where does it, what need, and I'm not saying needs as in multiples, I'm saying what is the need, where are the gaps in education? And it could be something there that NCLEX scores aren't scoring high enough, or it could be something where employers are reporting back that there's a deficit. It could be that there's been a new addition to the curriculum, or there's been something identified by an accrediting body. So where are the needs? Clinical faculty are coming back and saying that students are struggling in a particular area, whatever it is. Where are the needs? And then the objectives. You need to limit the objective. There are, more often than not, when we're working with faculty that don't have a large experience in simulation, is they want to put 5, 6, 7 objectives in the simulation, because again, they're trying to, accomplish a lot. But think about the idea of limiting it to 3. And really what happens is, if you can kind of separate those objectives, it actually improves learning, because now they're able to draw on prior knowledge that they've had from their classroom or maybe clinical experiences. They're drawing on that knowledge and then they're adding to it. And so limiting those objectives and creating a simulation that is focused on one thing, you're going to get much more bang for your buck. A lot of times you think of simulation as, let me do the extraordinary, right? I can't go into the hospital and have somebody have an acute MI on the unit that day so my students can see it. So let me bring that out in simulation, which is great, but not for a fundamental student, right? So thinking about your level of learner, and what is it that at the end of this course, so go back to your course objectives, what is at the end of this experience, at the end of this semester, do we want these students to be able to accomplish, but maybe it's a little bit more challenging or a little bit more difficult in a clinical setting? Or maybe we're augmenting. So I can remember early on, this goes back to the don't scare your students, but I'm not a psychiatric nurse, but we did 3 psychiatric simulations. One was depression assessment, where the patient was suicidal and had run their car into a brick wall at a high rate of speed. And the students had to go in and do a depression assessment and a safety assessment. The other one was a psychotic break, where they actually had to put the patient in 4-point restraints safely. And again, we had a lot of safety regulations in there, and we'll talk about the SP pieces of that. And then the third one was a patient who was borderline alcoholic, and they had to go through motivational interviewing techniques. And what came back to us from the psychiatric clinical instructors was that the students were scared to go into clinical, because they thought that they were going to get one of those 3 particular interactions. And so we did our simulations before they went into clinical. So we added at the beginning of the semester just a psych intake, where a patient had a little anxiety or a little depression, but it wasn't as challenging of a patient portrayal. And that was to give them an idea of what they're probably going to see. So rather than just the most challenging mental health cases that they may have, we also added in some others, so they had a point of reference, and it wasn't anxiety. It wasn't producing anxiety for them. So that was something that we learned along the way. And obviously, I feel like I started not with the dinosaurs, but at least with the alligators, maybe the early reptiles. I don't know.
And I think the important thing there to highlight is why we're talking about objectives in terms of psychological safety is because when you approach the simulation to be more challenging than what the learner can handle, it creates an improper power dynamic where you are basically setting them up where they will not be successful. If you are including 7 objectives with a fundamental student with something that is well beyond what they would be expected to know at that time. And that's what creates that psychologically unsafe environment when you're trying to put too much into the simulation.
Well, it goes into the idea of cognitive load theory. So if you think about being overloaded, is that the gap in knowledge is too great. So if you think about, we used to do all of our simulations before we did clinical. And then we had to move, our curriculum changed, so we had to move to a model where basically we were doing the same simulations week 1 with the students that were in the course as we were doing in week 12. So the people that were doing the simulations in week 1, they hadn't gotten the content, and they were doing 2 or 3 different simulations. So we had to be very intentional about our prep work for that, and also to help them understand that this is going to be a challenging simulation for them. And I don't necessarily condone that style, but it was something that we didn't have a choice based off of the way that the curriculum moved. So to think about putting things in context, the psychological safety of this is making sure that your students understand that the simulations have been created to stretch them to the edges of their ability. So you're almost saying, this is going to feel a little uncomfortable for you. And you're also saying, hey, if you feel as though at any point in time you're overwhelmed or overloaded, that's where that whole safe container concept comes in that they've introduced at Harvard, where, you know, there's almost a blue square on the floor, or there's somewhere that they can go just for a minute to think, and it's kind of like a timeout. And I think that's more applicable in a SP simulation than it actually is in a mannequin simulation, because if the SP can see them in that safe container, they know they just need a minute. Again, from the idea of creating that simulation with the right objectives, you're putting some of these things in place to make sure before the simulation even starts that they know that we've created this as a stretching ability. Harvard also comes out with the mantra, and I say it as a mantra, but it is not something that you should just have your facilitators read in pre-briefing, but it is something that they need to believe and embrace, is the idea that everybody that's entering to do these simulations is intelligent, capable, and cares about doing their best. And I think, again, what I always say to the students when they're struggling with, a particular, concept or doing something, and they don't know what to say to the patient, is to remind themselves and to remind the patient, I'm here to help, right? Because there's times where you're stuck. Well, it's the same idea. You want the facilitators to be reminded, this is what we believe, and you also want them to embrace that, at the same time. So that's that culture building. Policies and procedures go a long way. So thinking about having pre-briefing scripts with helping to help new facilitators, peer-to-peer evaluations to make sure that everyone is running the simulation the same way, and facilitating the simulation in a way that is going to be beneficial for the students.
And I think making sure that there is an environment that students can come forward and be able to share feedback about the simulation or the facilitation that they got. Because I've heard that several times, that people will, have conversations with me, whether it be through consulting or whatever, but they'll say, oh, the students just don't like to go into difficult sims. They just don't like that. And I think that there's an element that, yes, being uncomfortable in simulation doesn't feel great, but I do think that it does call for at least looking at the simulation to see, are we jumping the gun here? Are we putting too much in this simulation that they haven't actually gotten necessarily in class, or things along those lines? Or looking at the facilitation. As a standardized patient, I had experiences where I've seen facilitators run through, one of our psych sims that we had done for 7 years. I saw it done the same way over and over and over again. And then we went through a new training process, and we brought in 3 new facilitators for that one sim. And I got to see all 3 of them on their own. I saw them in training, and then I saw them when they did it themselves. And when I saw it, there was a very big difference to how they were approaching it. And one in particular was very aggressive in the debriefing process. When other people were in the room, that is not how she presented herself. But in the debriefing, it was very, why would you choose to do that? What was the thinking behind that? Pretty much, again, is there anyone in there, without necessarily saying, is anyone in there? And I remember that 2 students had come forward saying something, and they came to me because I was a part of the sim, and basically saying, like, did you notice anything? Did you see anything? And I was like, it is a very different style than other facilitators. At that point, that led to additional conversation. But I think that in that peer review, a lot of times it is the mindset of, I'm going in to grade a friend or someone that I work with. I don't necessarily want to be critical, but it is the checks and balances. And I think it's the very rare situation that someone's coming and observing you, right? It doesn't feel always great to have that. But having that standardized patient or listening to those learners, I do think that it at least can bring up the conversation that you're acknowledging it and not just brushing it off kind of with an eye roll or something along those lines, that they don't want to be stretched. I think that there are elements that can be the case, but there's also situations where there is something different that might be happening that you're not fully aware of.
And that's where you're, again, anonymous evaluations, and not just for the whole sim, but that you are finding out what date and time that simulation was happening, and you're making sure that there isn't any inconsistencies and things along those lines. There's a lot to be said for having that checks and balances, right?
Yeah.
So SPs are evaluating the learners as far as giving feedback. SPs are, maybe even giving feedback about the facilitator. Facilitators
Yep.
giving feedback about the if you think about it, if you think about Pam Jeffries' theory, there's these dynamic interactions. And when I wrote the article on adding standardized patients to that theory, you have other people now in the room. And so there really should be checks and balances all the way around. I think as far as the simulation, we've talked a lot about making sure that simulation is stretching students, but it is not pushing them or
over
adding
the
too
edge.
much. Yeah. And I'll say that over the years, it's not, even if you have 100 students that are in the same class and in the same cohort and go all through this, you're going to have a bell curve of students. So students that are struggling and students that perform and get to the objectives in much shorter time frame. And what I would always say to my students, and on camera you'll be able to see this, but if you're just listening to it on a podcast, I'll try to describe it. But what I would always say to the students, especially the ones that maybe weren't as prepared as the others, or struggled a little bit more, is if you come into simulation with this much knowledge, and I would put my hand about a foot off my knee, and I can get you to this much knowledge, and I would raise my hand about 6 inches. But then I would say my other hand about 6 inches over top. But if you come into simulation with this much knowledge, and I would put my hand up now to where they're even, so in other words, they came into the simulation with more knowledge, I can help you get to this much knowledge. So if students are struggling with just basic knowledge, and commonly it was a pathophysiology where they struggled, or even anatomy and physiology where they would struggle. If they struggled in some of these foundational courses, it was really hard to get them to understand how different medications would interact, or how some type of chronic condition would impact the physiology of a patient. So the idea is you can't necessarily get someone who's at the lower end of that bell curve to meet even the middle of the bell curve. You can get them up and get them farther a bit along, and also work with them to try to do some remediation, right? But you cannot necessarily stretch them farther.
Yeah.
And so
you're not going to get them from a 2 to an 8 in one simulation. It's what you were talking about earlier with being able to mold and do kind of the sculpture and things like that. It's like you've got to take little pieces at a time. This is not, the goal should not be that you're going to get them from that 2 to that 8 by just telling them everything that they're doing incorrectly, that all of a sudden they're just going to magically understand and then be able to be at that top of the bell curve.
Or that you can have that expectation. You really need to meet learners where they are. And that's the sign of a really good educator as well as a facilitator. But I think in simulation, because the groups are smaller, you just have more opportunity to see where each student is individually. So rather than a test grade, it's really how are they able to critically think? How are they able to take what they've learned in with their knowledge, with the contextual knowledge that they have, and now put it into actual action. And then I think what you were kind of talking about with the debriefing piece of this, right? You were alluding to that, but we have seen, there's tons of different debriefing styles. There's tons. But I think it's very, very important that when we are considering all the different debriefing styles, that you have some consistency, that when you're educating new sim faculty, that there is some standard of that, and that you are even providing them an outline, or what we had was an index card on a ring, and for each simulation they would have some pointed questions, and that followed the style of debriefing, and were appropriate for the objectives that were set. And I think that it's really important that you are helping. A lot of times when we talk to in our consulting, there's multiple different campuses, and not every campus does it the same way. Whoever is your sim champion, if there's one sim champion at one campus that is really kind of leading that for all of them, that sim champion then needs to help those other campuses. Whether they have the power or the ability to do that, I can't say. But what I will say is that there is not a dean or director that I have ever met that would not say that it is important to them that we are following best practice standards. That I will say. I don't think that anyone has ever said, hey, it's not that important. Best practice isn't that great. Because we're healthcare providers, and best practice is so incredibly important. So from my perspective, the idea of pointing it back to best practice standards, advocating for a full-time sim champion that is helping to reinforce the standards of best practice. It may not happen tomorrow, may not happen next week, but I will say that rather than just saying they're doing it wrong or the students hate simulation, but to say we are not following best practice standards is really the best approach. In my mind, it's the best approach.
So how would you say that having different debriefing styles ties back to psychological safety?
So as far as thinking about how if a lot of places that I'm referring to, they have adjunct faculty. So an adjunct faculty member is someone who is a bedside clinician that agrees to come and take a clinical group for a semester into the clinical setting. But a lot of times associated with that is a day or two of simulation. And that clinical or adjunct faculty member is expected not just to be a clinical instructor, but to be a simulation instructor. And they're not the same thing. So if the clinical instructor runs that debriefing session as if it's a post-conference in the hospital, they're not following a debriefing style. It's just a very different way of communicating. And they also become a bit, and I'm generalizing and stereotyping here, but they become a bit concerned about are these students going to make a mistake in the hospital with the patients? Because as a clinical instructor, you have 8 or 9 or 10 students. You can't possibly be in all rooms at all times. So they want to fix the learners in the debriefing process. And the way that learners learn in debriefing is by self-reflection and by peer discussion, rather than the instructor saying, you did this right, you did this wrong, you did, don't do that, you could kill your patient, right?
Or
so that doesn't.
You just did kill your patient right there. Yeah.
Yeah. So what happens is what makes a good clinical instructor, even if they are a psych clinical instructor, does not necessarily mean that they are a good simulation debriefer or instructor.
Well, and especially with not practice. And I think that's the key part that is always missing, is that when you're bringing someone in as adjunct faculty to fill in for simulation for a semester or for a month or whatever it may be, simulation and debriefing is a learned skill that comes with time. I think it's a love that grows. I don't think that there's a lot of people who are like, I love simulation, that's why I got the job. I think a lot of people are like, I just volunteered for this job and then eventually ended up falling in love with it. I think that's the more normal track that a lot of people took, or they didn't know what they were getting into when they signed up for simulation and then eventually we're like, this is awesome, I love this. But that seems to be the normal track. So when you have people who are coming in who don't necessarily love simulation, you then don't have policy and procedure for what your standards are in terms of how you do debriefing, what your debriefing style is. You don't have a training process for training them on how to debrief, and then you put them into simulation and say, well, just do your best, right? I think that's the normal situation that ends up happening. And from there, I think there is expectation that you're just going to magically know what's in my head, and that's just going to magically, through osmosis, you're just going to know and be able to run into that debriefing room and be able to run that the way I would. And I think that that's not a fair expectation. But when you can go from a top-down situation, because I think a lot of times we go bottom up and look at it, it's like, they're the problem, it's the issue, we can't have this. But if you look at it from a top-down situation, you say, I can't control who's going to come in, because again, a lot of us in sim, we don't have control over hires, we don't have control over getting the help we need.
Probably the people that are listening to this do, but yes.
Well, we want to advocate for being able to get the help we need.
Definitely.
But I've seen a lot of changes and a lot of turns over the last few years, honestly, since COVID. But a lot of times I think people are just feeling powerless. What we can do inside of simulation as simulation champions is work on developing policy and procedure that goes back to best practices, like you said. Because then you can say, I've developed a policy and procedure manual on simulation that follows all of ANAXL SSH best practices. Dean Director, please feel free to review, right? And like you said, they're not going to look at that and go, we don't need standards of best practice here, right? For the most part, there will always be exceptions. For the most part, they will accept that as best practice. Once you have that as policy and procedure for your simulation lab, you now have a leg to stand on when bringing in adjunct faculty to say, our policy is we need 3 days of training. We need, all of these things. They need to have remediation. They need to be followed. They need to shadow. They need, all of these pieces. And what will come out, I'm sure, is, wow, that's a lot of investment for simulation, faculty to be involved, right? And then you say, yes, it is. It is a big investment because we have to stick to standards of best practice. Here we go. And if you are an accredited sim center, that kind of argument just goes out the window because then you're accredited. So to keep up your accreditation, well, this is just what it has to be.
But my experience is that you still have to fight for it.
I think it's always a fight. I don't think anyone in simulation ever goes, oh yeah, everything's so easy.
Have
Everyone
full budget.
They love it. Everyone adopts it, right?
Yeah.
I think it's always feels like a fight, but you at least have some sort of backing.
Advocate.
Advocate.
That's
there we go.
probably the better
Advocate's
word.
the right word. But at least you have some sort of backing, because I feel like without that policy and procedure, without that training manual, you don't have a place where everyone can come and agree, because then you just have, well, Susie says this and Sarah says this, right? It's two different things and it's two different opinions. But when you now have policy and procedure to back what you're saying,
Yeah.
It's a different conversation. So that is what I always encourage people when they come to me about, changes coming in and who's coming into the sim lab to do debriefings and skills lab and all of these things. I always say to them, what does your policy and procedure look like? Because that's the easiest way to start to create a framework. Now, you have to be able to get buy-in from leadership, but it creates a framework.
And I will say that we definitely did that backwards. I didn't have strong leadership training or really understand the importance of policy and procedure. It took us a long time to get to policy and procedure.
It was the Wild West. It was just the Wild West for a long time.
It probably should have been the first thing we talk about, because I think that actually even goes in before you're setting the objectives or doing your needs assessment, is what is your policies and procedures behind this. There are so many sim centers. Again, Simulationist, share. So Simulationists help Simulationists, guys. There are lots of people that are willing to share their policies and procedures. Yeah. You don't have to start with nothing.
Yeah.
ChatGPT is another option, but just know that there is a lot of people out there that are willing to share theirs. And so don't be afraid to ask. Look at 3, 4, 5, see what is integrated. You talked about the idea of accreditation. The other idea is endorsement through ANAXL. So ANAXL will endorse you to say that you're doing good sim. If you are endorsed, there's going to be some standards.
Yeah.
There is also some good reinforcement through the National League for Nursing. So there are options out there. But I think the path of least resistance is to start with that policy and procedure and have that be your foundation for everything else that you do, and your decision making and your advocacy. So if, again, we had to change our curriculum, now all of a sudden they wanted to include clinical instructors, and it just, because we had policies and procedures that required training and required all of those things, things got to the point where we had identified simulation champions and simulation faculty. One of the things that Sam Houston does is they have specific faculty that are trained to do all of the pediatric simulation. So that subject matter expert is the facilitator for all of the simulations in pediatrics, which I think is really cool, right? Yeah. So they've invested in a few more simulation faculty members, but they've invested in people that are sim champions within each of the different specialty areas that they have simulations in, which I think is a great idea.
Yeah, I completely agree. It really helps with, especially including standardized patients, it really helps with creating that standard.
Yeah. All
right, so let's talk a little bit more about the standardized patient side of things, because there is, similar to what you were talking about with Pam Jeffrey's simulation model, and then you going in and adapting it, including standardized patients, it really does change the conversation, because there is a whole nother component that comes along with this. So whether it just be standardized patients or also a standardized patient educator, but both of those people are now a new member inside of it. It's kind of like, I don't know how to think of it in terms of like family realms, but it's like if you just had you and your kids and like that's how you guys operate, and then now there's a new stepmom and a new stepdad, and like I don't know how to say it, but it changes the family dynamics. Everything just changes inside of now.
That's exactly how Pam describes it.
Yeah, we got to rethink it all. We got to rethink the way that life was before, because now we have these two new people, and to just assume, oh no, you guys are just going to blend in the way that we do with our mannequins, and basically like this is all just going to flow the same way it did before.
Retract mannequin, insert SP.
Exactly, as if it's just that easy, that you're going to start to face some challenges. So being able to just first address the fact that there will be changes. If you do start with standardized patients and then eventually add a standardized patient educator, when you're adding that educator in, it's the same thing. You got to go back through your dynamics and rethink how this is going to work, even just from basic communication. I'm going to start with what you're looking for, though, in a standardized patient that creates psychological safety, because we were talking earlier about the culture of creating that in the sim center. Your standardized patients are also a crucial member to make sure that they are also psychologically creating a psychologically safe environment. So we are looking for theirs, but we also want to make sure that they are exuding that. So one of the key things you're going to look for is when you're bringing in a standardized patient, always start with interviews and auditions. And one of the things you're looking for is if someone says that they want to fix healthcare or they want to fix the healthcare providers, that should always
or
be.
Or if they're describing noxious experiences with healthcare.
Yes. Those should all be red flags, because when that happens, what's going to happen down the road is that they will start to take over the debriefings. They will come into simulations with a chip on their shoulder or an agenda that they're ready to talk about. They will also feel like because they've maybe had those experiences, they know better, that they know what it's really like to be the patient. So they're not going to necessarily only stick to the objectives. They might add in their own objectives that they want to add in to get points across. That is not a person that should be a standardized patient. They might be an amazing patient advocate, and I say this a lot. Patient advocates, standardized patients, not the same. So I'm going to talk a little bit about the characteristics of what you're looking for with a standardized patient to make sure that they are creating a psychologically safe and culture for simulation. So
for the learners.
For the learners.
Yeah.
So again, not just looking out for their psychological safety, but also that they are exuding psychological safety. So part of that would be doing an interview and an audition. You want to catch in the interview if someone is there to try to fix healthcare providers. We want to make sure that when they're coming in with the mindset of, oh, like maybe they want to volunteer, and that's fine. But we also just want to make sure they're not coming in with a chip on their shoulder to try to fix anybody. I think that's the big thing.
Like if they've had noxious experiences with healthcare, or they have some type of chronic health condition, or a family member does, and they haven't necessarily had great experiences, that's not necessarily the person that you would select for your...
And I think you can usually read that. You don't need to get too far into it. I think you can normally tell through basic conversation, is this someone who has a chip on their shoulder or not? But just know that kind of through the conversation, you can usually determine that. The next part would be in the audition phase, looking for anyone who leans towards a hyper emotion. So anything, you obviously want there to be some emotion and some baseline things, but anyone who's going to go from a 0 to 10, which is not appropriate for the simulation or for the scenario that they're portraying, you want to coach them. And you want to say, okay, that was a 10. Let me see you at a 4. Let me see you at a 5. And if they're coachable, you can work with that. That makes sense that you have the ability to work through that. But just someone who's not coachable, who is leaning to the highest level of those emotions, that can now very negatively translate into simulation. It's going to affect standardization, which you don't want, but it's also going to really, again, could be a very noxious experience for those learners if they go into that sim and then that standardized patient is overly emotional in what you want. The last piece, similar to the coaching notes in terms of their performance, but also in their feedback.
Well, before we get into that, I just want to say something, because as a simulation educator, I can hear everybody that's listening to this say, I don't have time for interviews and auditions. Mm-hmm. And we don't have time for the mannequins to break down either, right? Mm-hmm. But if you take the time in the beginning and lay that foundation, you end up with such a better result at the end. So just so you know, we did a 15-minute interview and a 15-minute audition.
Yeah.
And we would stack them. We had certain times, and we would do one right after the other. And we had it was basically at that point, Megan was working as a sim intern, I guess would be, and Rob in doing the interviews. Mm-hmm. And then myself, sometimes I would be there, but typically Alan, we had our SP educator, our SP champion, doing the auditions. Mm-hmm. So it's not, you don't need, 10 people there.
No.
You don't need gobs of time. I think we spent probably a total of 7 hours at the end of every semester. So the way that ours was an actual course. So the students that were enrolled in the course had to go through an interview and audition before they would be accepted into the course. So we did it before enrollment. Mm-hmm. So we knew how many students were probably going to sign up, and two, they knew that they could sign up for the course.
Yeah.
So it was about a month before the semester ended that we would do that, and it was a grind, but it was worth every bit of time that we did that.
Yeah, my other recommendation would be if you are looking for how to conduct it, because we've heard that several times, I don't know how to conduct an interview and audition. We do a lot of webinars on it, so just be on the lookout for when Avkin's going to be putting out a webinar on interviews and auditions, because it's something we're very comfortable with, and I think that a lot of people get very intimidated by the thought of it. Yeah. It's very simple. I feel like every time we do it, it's like, it's so easy. It's very basic, but it is nice to have a framework going into it if you've never done it before.
Yeah. Yep. Great.
So the other piece would be with the feedback. So thinking about that same concept of coaching, you want them to be coachable in their feedback. Feedback is a skill that needs to be learned from standardized patients. It is not the opportunity of just, okay, start talking and let's see what happens over the next, 5 minutes of you speaking. It is a very structured way of approaching it. We do the sandwich technique just because it's easier with standardized patients, being able to teach them the sandwich technique. We don't go teach them the debriefing techniques and things along those lines. We go through and we teach them feedback skills. That's where they do.
We do teach them when they will be asked for their feedback.
As a part of the debriefing.
Right.
But inside of their own debriefing, we coach them on what are the appropriate feelings of the patient. We don't want them to say things that are very harsh, especially when it's not appropriate for the level of what's actually taking place. So if they were to say, oh, the patient felt violated when you touched my arm to give a blood pressure, right? That's not appropriate. That's an extreme word for what actually happened. So we really make sure that we are coaching them and that they know the weight of their words for the people that are coming in. That's something that we really, really focus on. Yeah. And next piece is that in the character description, they always know the level of learner. And during dress rehearsal, we really make sure that they are aware that they are not there to expect a fundamental student to be the same as the nurse that they see in the hospital. It is not going to be the same, and they need to have appropriate expectations of what those learners are going to be. Sometimes that comes with coaching. Sometimes it's hard to get that across, and they may not be the right person, but it is important to know that they need to know the level of learner and that their expectations are appropriate in regards to feedback as well.
Mm-hmm. Mm-hmm. For sure.
The next component is thinking about the psychological safety of the standardized patient. So not only what they're bringing to the table in terms of being able to make it psychologically safe for the learners, but also making sure that that other live person in that simulation is also safe. So ASPE, the Association of Standardized Patient Educators, their very first domain is safety. So discussing the safety of the standardized patient. So that can be physical as well as psychological. The very first component when it comes to psychological safety is we allow any standardized patient to opt out of simulation at any point. There is no expectation that they have to be a part of the given simulation that they were assigned to. Even if they agree to it, they sign up for it, and then later on find out that there's a component or a piece they don't want to be a part of. It is a no harm, no foul situation. They can at any point opt out of that simulation because we don't want them to ever feel pushed or pressured to go into a simulation with something that they're not comfortable with. So really at any point right up until the sim, even in the sim, they have the option to opt out of that simulation. Because of that, we try to do extensive training, making sure that they are fully aware of it. So part of that is during the dress rehearsal, they do act out that role. And again, at that point, they are able to opt out of the sim because now they actually get the full understanding and are able to act out that patient. The next component is just the physical safety. When you are thinking of doing a sim, I always want people to think about themselves doing that simulation. So if that means that, these 3 students are now going to move this patient from this bed to, you know, a chairlift or something along those lines, right? Think about, are you comfortable with that level of learner putting you in a lift and moving you? Does that feel safe? If it does, feel free. If you're like, absolutely not, there's no part of me that would be doing that, do not ask another person to do it themselves. That also goes back to thinking about masks, thinking about other clothing items, asking people to rewear things. Just think about if you would be comfortable doing it, ask your standardized patients. If you're not comfortable doing it, you shouldn't be asking someone else to do that thing.
So I have a funny story with that one. One is the idea or the concept that there is obesity suits that are out there. And I believe they were made for the mannequins.
Yes.
But there are times where, again, some well-meaning instructors think, I want to do an obesity sim. Let's have our standardized patients wear this. And I had one particular instructor, and I was trying to explain to them, hey, this isn't an appropriate ask because they're going to have to wear, there's no way to clean it. There's no way to wipe it down.
Cloth.
So, the wearable simulators that Avkin makes, all of them are wipeable, they're cleaned, you wear...
Because I knew I was going to wear it after people, so I made sure that they were easy to clean.
Sure, and that's the important part. But what I said to that instructor was, if you'll wear it at the end of the semester, after everybody else has worn it, and you'll wear it, then we can do it. And she's like, absolutely not. And I said, that's exactly what you're asking for the SP. So that's just one way to advocate. Again,
it all sounds great, and then it's the realities that really start to change that concept.
Well, and I think that they are human beings. They are real people with real emotions. They may have had, you talk about that they could opt out in the midst of a simulation, or they may have had no experiences with anybody with breast cancer prior to the semester and be fine, and then all of a sudden a close loved one gets diagnosed, and then it's too close to home.
Yeah.
So, again, think about it from the perspective, and because we taught a course, there was still a power dynamic. We really had to be very clear that it was okay that you could opt out.
Yeah, and there's anonymous opting out, and things along those lines. But I think the other component with opting out is remembering to, like you said, things change. I was the person that prided myself that I could do any sim. I could do anything. I could do it anywhere. I remember me and another SP, we were talking about, she's like, shave my head, put me in the bathtub. I don't care. I'll do whatever it takes. And I was the same way. I was like, whatever it is, I'm down for the sim. It's super fun. I want to do it. And then I had a baby. And when that happened, all of a sudden, any type of pediatric, again, fatal, anything that was even just like a bad injury, anything like that, all of a sudden was just a no-go. I can't do it. It just, every time I think of my own child. And so all of a sudden, someone who prided themselves on being able to do anything and everything now had this huge, okay, this whole catalog is now off limits. I can't do any of that anymore for the time being. And maybe it will change once, my child gets older and they're no longer in that, age group of 18 months and things like that. But it was a huge shift. And it was even hard as the SP because it was something that I like to do. And I in my head, I'm like, no, it's fun. And then I'm like, no, but you won't have fun doing it anymore. Like, you got to remember that. But it is this challenge that even you as the SP, so having that from the SP educator and also other faculty members being able to say, like, it's okay to not do it for now, or it's okay to opt out, it's okay to change your mind, and being very open to that, I think also helps that standardized patient. Because sometimes they don't even really know what those limits are until they're actually in the bed. And then it really changes things.
And it's also, telling them, if you get a spidey sense in the midst of trying to read this character description, or maybe they're watching a video in preparation, if there's just something that feels off.
Yeah.
But again, it's very rare that it happens.
Yeah.
But it is something that you do want to give them permission. They are human beings. They have emotions. And we should not be doing further emotional, psychological harm to anybody. So, it's just something that, again, ASPE covers it, but we want to make sure that we're talking about that.
We don't want to do any harm to any live people in simulation ever. And then just the last part is just considering, again, going back to the physical safety, not only the movements and the changing them from beds and things like that, but also what's in the room. I heard a very scary story once. I was not a part of this. This was at a different institution. But they had a defibrillator in the room.
A live defibrillator.
Yeah, something that worked. And when they just had it there because it was just, it makes the room look realistic.
Well, no, they had done a different sim earlier that day.
But they were like, who cares? It's just in the room,
it's
right?
Just in the room.
So this sim with a live person had nothing to do with needing the defibrillator. And when the student walked in the room with the standardized patient, when they saw it, they assumed that they were supposed to use it in some way,
it was a prop
shape, or
in the
form.
room, yeah.
So it got to the point that this defibrillator then ended up on the table, and I don't think that they actually
they scooted it over. It's on wheels, so they scooted the cart over towards the patient.
And I think that it was next to them for a period of time, and I don't think it ever ended up on the patient at any point.
They had to call the sim.
They called it before it ended up actually on the patient. But there is a real concern that if someone was not paying attention, if someone was left the room to go for a bathroom break really quick, again, having these live pieces that can be used that could actually potentially cause harm. So again, think about your fake medication. Think about, all of these other things that could be in the room. You want to make sure that all of those things are removed. So sharps is the other consideration to make sure that if sharps are a part of the simulation, that they're in the pre-briefing discussed where the patient can be stuck, what is the whole safety protocol. It needs to be a part of the dress rehearsal so that the synchronized patient is fully aware of that. And then during the pre-briefing, it needs to be discussed, if not shown.
Shown.
So that they are aware of where that patient can be stuck.
This is your injection pad. It will be on the belly, or it'll be on the bicep, left bicep, whatever it is. That needs to be made very clear. But you also need to have a safe word.
Yes.
Or an Avband.
Yes.
To allow the SP to identify if they feel unsafe, if they're unsure. Because I think as healthcare providers, we know, we wouldn't take any of that simulated medication because we don't, it's not.
It's been there for years, probably.
Whatever. Or it's, please don't have any expired medication that somebody's dropped off.
No, do not do that. Please do not do that.
Whatever the case may be, again, you as an educator know what is acceptable and what isn't, but you can't assume that a non-clinical healthcare provider would know. So they need to know, do not allow them to put a needle anywhere but in the AV stick or in an injection pad or wherever, right? Mm-hmm. They need to know that there's 4 layers of safety in the AV sticks, that they're not going to get harmed. Again, you've done a lot of work to make sure that the SPs are safe. But conceptually, where can they do this? Mm-hmm. Because if they feel unsafe, they need to be able to identify that.
Well, and the synchronized patient needs to know all of this as well. Again,
yes,
I have gotten stuck in the past. It has happened. And again, that's...
Not when I was the facilitator.
But that's the kind of stuff that for me, I was like, it's fine. It's okay. I'm not going to break the sim. Again, this whole overtly dedicated to being a synchronized patient. I was like, it's fine. It's cool. It's fine. But when we would train on it, it'd be like, no one's getting stuck. This simulation will end before that happens. Break the simulation. And that's where we came up with the safe word and things along those lines so that there was the ability. Because at that time, I would have just been like, stop, don't do that anymore. I didn't have a way of ending it. Right. So having that safe word where it does pause the sim, it stops everything. But also on the Avband, there is an orange button that the synchronized patient can press, and then that cues back to the facilitator in the room so that they know that something's wrong, they need to end the simulation. But with all of that, the biggest thing is if you're going to have sharps because it's a part of the sim, it has to be like a well-choreographed dance. Everyone needs to know their part. Everyone needs to know what's happening. If it is not a part of the sim, do not have it in the room. Just take it out. It is not worth the risk of having it in the room. Well, this has been our time for Simulation Nation on psychological safety with students and standardized patients. Thanks for joining us.